Hello guys, this is Dr. Shannon Clark and I am about to go live with Dr. Amy Schutt to discuss PCOS and fertility. So I'm going to wait a little longer to see, give her a chance to join. So hang tight. If someone could just let me know if you can hear me okay right now, just give me a comment to let me know that you can hear me. And then once she joins, I'll ask again. I am at our beach house, and so the reception's not the greatest. Oh, there she is. She's going to be joining soon. Hi.
Hi, how are you, Shannon?
I'm doing so well. Today is officially my first day of vacation, so I'm trying to adjust and clear my head, which is hard to do. It's been a long 5 months, so I'm sure you
Oh my
understand.
goodness. Well
Yeah.
deserved. Well
Thank you,
deserved.
thank you. Well, we have a bunch of people already on, so I want to jump right in. I
hmm
want to thank Dr. Amy Schutt for joining me on this very important conversation about PCOS and fertility. Again, I'm Dr. Shannon Clark with Babies After 35. I'm also a maternal fetal medicine specialist. Dr. Amy Schutt, you are a,
I'm a fertility specialist. I'm up
right?
the road in Houston at Baylor College of
Yeah,
Medicine. So I specialize in endocrinology and fertility.
perfect. And can you just right off the bat tell people how they can find you on social media or whatever social media channels you might have?
So primarily Instagram, Amy
Mm-hmm.
Schutt MD on Instagram is
Mm-hmm.
where you can find me.
Okay, perfect. And thank you so
Yeah,
much for taking your time out on a Sunday to do this. And I apologize if I pronounced your name wrong. It's Amy Schutt. So
no worries.
Schutt. I'm sure you
Yes,
probably get that a
yes.
lot.
All the time, all the
I
time.
know.
Yes.
I have a very easy last name, so it's kind of hard to mispronounce. So I am sorry for that.
No
Okay,
worries.
let's dive right in.
Happy to be here. Sounds great.
Thank you so much. Thank you so much. So let's just start from the very top. What I'm going to do is ask a bunch of questions, talk a little bit, and then I'll go back through and scroll through it and see if there's any questions we need to answer. So first off, just what is PCOS?
Well, this is a wonderful question. I talk about
Mhm.
this every day with
Yeah.
patients, and I think the first thing is that PCOS is a misnomer. Okay, so we
Hmm.
talk about the term polycystic ovarian syndrome, and I think it has this very negative connotation, right? Meaning
Hmm.
this polycystic, we think cysts are this kind of pathogenic or painful thing, but
Hmm.
really the important thing to know about PCOS is the polycystic component is essentially follicles in your ovary, so eggs, okay?
Hmm.
And really talking about what is PCOS, well, we argue as physicians about what criteria, make PCOS what it is. But primarily, if we think about three major components from the Rotterdam criteria,
Hmm.
we talk about menstrual cyclicity, or as in PCOS, what is the irregularity of cycles? So
Hmm.
classically in PCOS, we have irregular menstrual cycles, okay, which can lead to infertility
Hmm.
or problems with the endometrium. But typically, irregular ovulation, irregular cycles, number one. Number two, on ultrasound, morphology of the ovary. Okay, where we see enlarged ovaries, multiple quote unquote cysts or follicles, and that leads into the metabolic component of PCO, which we'll touch
Hmm.
on later.
Hmm.
Okay, and then androgens. Androgens refer to testosterones or hormone imbalances in the ovary and in the body. And so classically, we see elevated androgens, testosterone, or even DHEAS levels, which are made in the
Hmm.
adrenal glands. So if we think about the three criteria, irregular cycles, PCO appearing ovaries, which we can talk about in more
Hmm.
detail, and elevated androgens requiring two of three of those criteria to make the diagnosis. But we know that PCO has different phenotypes, which means it can
Hmm.
appear different woman to woman. There can be
Hmm.
not one size fits all. And so I think the most important thing when talking about PCOS with a patient is what is your goal for therapy? Is
Yeah.
your, what is your concern? How can we help your symptoms?
Yeah, so I know I trained in residency to do my OBGYN residency from 2000 to 2004, and I know a lot has been changed as far as the diagnosis. We typically were taught PCOS was in overweight women with irregular menstrual cycles who had signs of hyperandrogenism or whatever, and that's not necessarily the case. So we can't just assume it's PCOS based on the way the patient looks, and we can't assume that it's not PCOS because she's not overweight or she has a different type of appearance. So I think out of the three, what would you say is the most um, the kickoff? Like, what would prompt taking fertility out of the question? What would it be about a woman's either how she appears or what's in her medical history or what she's currently experiencing, which one is the one that would kind of say, you know what, I'm going to go down this path with her as far as seeing if she's got PCOS?
Well, I think that's a great question. It's a tough question because
Yeah,
every woman is so different,
so
right? I
different,
mean,
right?
if you showed me 10 ultrasounds of
Hmm.
ovaries, I could probably pick some out pretty clearly.
Yeah,
But a challenge also is young, healthy women in their late teens, early 20s can have PCO appearing ovaries and
hmm,
not have
right.
PCOS. So I think probably menstrual cyclicity or
Yeah,
amenorrhea in the absence
hmm,
of another diagnosis or irregular cycles is probably, the most important factor. But again, like you alluded to, there's not just this classic appearing
right.
PCOS, right? And so I think importantly to mention is, the underlying metabolic disturbances that we
Yeah,
see, like women are predisposed, as you see women with gestational diabetes,
right.
hyperinsulinemia, problems like that. Even women who are thin who have
Hmm.
PCOS have a predisposition to hyperinsulinemia, prediabetes, hyperandrogenism. So I would say menstrual cyclicity probably is the most common complaint, but not always.
And just while we're on it, I'm a maternal fetal medicine specialist. I deliver a lot of babies
Mhm.
and a lot of high risk moms for whatever reason. And one of the things I've heard pregnant on my own or ever get pregnant because I have PCOS. I don't think, and you can correct me if I'm wrong, I don't think it's a fair thing to say to anyone, especially at such a young age. I hate to hear these stories when women, may have started getting a workup younger, and then a doctor tells them, well, you're never going to have babies on your own, or you're going to need help, or even that won't work. What are your thoughts on that as far as labeling
Okay, so
women that early? Yeah.
no, I completely agree. I'm very hesitant to put a label on, and I tell women too, I don't care about the label. I care about
Mm,
what are we treating, right? If you're
yeah.
young and you're coming to me for PCOS, not fertility, you're coming for some reason. Either your
Yeah.
cycles are irregular or you have hirsutism. And so I really tend to not put a label, you have
Hmm.
PCOS. I do try to say clearly, look, I don't want you to have stress for the next 10 years. Will I not
Yeah.
be able to have kids because I might have PCOS? I think a really important message too is that there are things that we can definitely
Yeah.
do to help you build your family if that's your goal, if you do have
Hmm.
PCOS.
Yeah, exactly. So I think it's important. I hate to hear that, they've carried this burden on them. So even when they're ready to
Mm-hmm.
have kids, somebody told that they've carried this weight on their shoulders for years and ultimately either get pregnant on their own naturally or with the help of assistance if it's needed. So I just hope that, I just feel bad when I hear that story. So I
Mm-hmm.
hope that that's not, you know, changed a lot since I've been in
Definitely.
residency as well. Yeah, go ahead.
Yeah, I
How's it
completely,
diagnosed?
great question, Professor. You cut out a little bit. I wanted to make sure I didn't miss some of the message, but even if you have PCOS, it's not a death sentence for fertility. Okay, so that's really, really important.
Mhm.
And Shannon, can you hear me because you cut out a little bit? I want to make sure
Yeah.
my connection's good.
Yeah, no, I can hear you. Yeah, I can hear you
Okay,
fine.
good,
Yeah.
good.
Okay.
Okay,
Yeah, so the next topic I
okay.
want
So
just
when
is
we
how's
when
it,
we
yeah,
diagnose PC,
hmm.
yeah,
I'm sorry, just how is it diagnosed?
yeah.
There might be a little bit of a
Okay,
delay.
so
That's okay.
typically, okay. So in terms of diagnosis, first I talk to you and so figure out what is your gynecologic history? What have your cycles been like? I think an important misconception also is that somehow the birth control pill or hormonal contraception
Mhm.
may have caused my periods to be irregular or may have caused my PCOS because commonly women will go on birth control pills when they're young, a teenager, and they have regular periods for decades, then come off the pill trying to get pregnant or just come off the pill and then whoa, irregular periods. Okay, so that's one thing is the birth control pill is an effective treatment for PCOS, but it also can mask the underlying, okay, menstrual cycles. But first to talk to you and figure out what are your cycles like. And if you say, well, Dr. Schutt, I get periods maybe twice a year or every other month. And if you're trying to conceive, if you say, I have no idea when I'm ovulating, I never get a positive ovulation kit, okay? So talking to you, getting a history about menstrual cycle is important. That's number one. Number two is we have to exclude other medical diagnoses that cause irregular cycles, right? So there can be things like elevated prolactin or thyroid imbalance that we have to make sure we exclude as a cause for irregular cycles. But one, getting a thorough history about your cycles. Two, we do an ultrasound together, okay? We measure the ovaries, we measure the follicles that we see. And so criteria by ultrasound for PCOS are if the volume of the ovary is more than 10 cubic centimeters, reflects a higher egg count, or if you count more than 12 to 15 follicles in the ovary. Sometimes in the ovary, we can see something called the chain of pearls appearance, where there is a ring of follicles around the ovary. Then that's pathognomic or diagnostic of PCOS. And again, the PCO, the polycystic appearance, if there's a silver lining in PCOS from a fertility perspective, it's that women with PCOS tend to have an above average number of eggs in the ovaries, or said another way, an above average ovarian reserve. And it's a little bit paradoxical because that extra number of eggs can be helpful later in life in building a family, but it also can make your cycles irregular. So one, getting a history, two, ultrasound, three, lab work, okay? So in the lab work, we're checking for, again, those androgens, looking at testosterone levels, looking at DHEAS levels, also looking at a hormone called anti-Mullerian hormone, where AMH is not in the Rotterdam criteria for PCOS, but more data is coming out that AMH levels are consistent with PCOS diagnosis. So lab work, ultrasound, and getting a good history.
Yeah, good. I just moved outside because I got a message that I was cutting out. So if someone could just let me know if this connection's a little bit better, hopefully it will. So I do apologize. Okay. Is it better?
It's better.
Okay, good. So it's probably the Wi-Fi that's here. Okay. So we talk about the risk to women who have PCOS. I think, and you touched on this, one of the major risks is due to the lack of ovulation or anovulation or irregular ovulation, which it could be probably any of them. So what is it about specifically, and again, we're going to talk about fertility in a little bit, but what is it specifically about women that are having ovulation issues that's the problem?
Okay, well, that's a great question. And you touch on a point that I think is really important, where I tell all patients that their health is the number one priority. Fertility comes later, but you have to be healthy. And in PCOS, if a woman has anovulation, okay, or meaning if she has no periods or very infrequent periods, less than 3 per year, she's at increased risk for endometrial hyperplasia or endometrial cancer, which means it's too much estrogen and not enough progesterone, which is protective of the uterus. So some of the risks for PCOS from a metabolic perspective are uterine cancer. And sadly, even women who are in their 20s or 30s, I've seen have developed if this has gone unchecked for many years.
And would you say, and again, I do apologize, I did residency a long time ago, but if you have PCOS and obesity together and not having regular menstrual cycles, does that further increase? And I know that you could see some of the earlier stages of endometrial cancer earlier in women that had those two combination. Is that true?
That is true. So obesity definitely still is an independent and synergistic risk factor for endometrial hyperplasia and cancer and PCOS. Some of the other metabolic effects of PCOS are independent of obesity, but age and obesity definitely exacerbate the risk of uterine cancer and PCOS.
Right. So I think it's important, a point to keep in mind too. If you're not having regular menstrual cycles and you're overweight or obese, or you have a higher BMI, that's even more of a reason to make sure that you're getting checked and evaluated to see what exactly is going on. And I talk about this, I brought this point up all the time. Recently, in all the talks I had a young woman come to me who was in medicine. She's in training. And she said, "Hi, Dr. Clark, I follow you on social media, and I have maybe 3 periods a year. It's been like that for several years. It didn't start out that way. She's not overweight, but the doctor responded to her and said, well, whenever you would decide to get pregnant, we'll just give you Clomid." My response to her was, well, no, we got to figure out why you're not having periods. The time to figure out why you're not having periods is not when you decide to become pregnant. As Dr. Schutt said, your health has to come first, and we got to figure that out, because not only is that important for you, but should you become pregnant, we need to know what your baseline health is anyway. So please, if you're not having regular menstrual cycles and you don't know why, get that evaluated so it can be corrected and evaluated, and then have that squared away before you do get pregnant. Would you agree?
100%. And I mean, I completely agree. And we're taught in fellowship and residency that PCOS is a diagnosis of exclusion, right? So after we've checked every other
everything
axis,
else,
and we don't want to miss, a microadenoma or a benign brain tumor or some other major, diagnosis, and just say, oh, it's probably PCOS. No, it's definitely worth getting checked out.
Right. Okay, so let's go into, if someone has a diagnosis of PCOS and it's made, but she does not desire fertility at the time being, or having a child, what are the treatment options for her, or potential treatment options?
Okay, great question. So I'll throw it back and say, I'm going to ask her, what are her goals? Okay. And what are the primary complaints? If it's irregular cycles and a desire for contraception, okay, I don't want to get pregnant, I want to have regular cycles, then combination oral birth control pills are an excellent first choice for many women. And the reason is this. So I'm often asked, can I cure PCOS? Can I fix PCOS? And that the answer back to that is not really. Okay, we can improve metabolic parameters, but the primary cause of PCOS actually is in the brain, and it's related to hormone secretion. So the birth control pill is incredible for PCOS for many women, not all, as long as there's no contraindication,
right?
Because it lowers bioactive testosterone levels. So it definitely helps clearing skin. It helps with acne symptoms. It helps with hair growth that's bothersome. And it protects the uterine lining and causes regular cycles. So if the complaints are related to, hair growth, acne, irregular cycles, birth control pills are a great option. If the complaint is hair growth, then that becomes really more individualized. Mechanical hair removal, there are other hormone, other medications that we can use, but some are not safe if a woman is trying to get pregnant. So we have to kind of individualize it.
Right. So let's talk about the woman who has a diagnosis of PCOS and desires fertility. Would you say that, say she has this diagnosis, it's been, she's been on OCPs, or that woman versus the woman who is coming in for infertility at baseline and then the diagnosis is made. So how do you approach each one of those women? We'll talk first about the woman who already has a diagnosis of PCOS and desires fertility.
Well, I think I should back up and say that even for a woman who does not want to get pregnant, an important component is metabolism. Okay. So talking about long-term health, long-term metabolic health, that women with PCOS, they metabolize glucose or sugars differently. Okay. And even if they're thin PCOS, they're more apt to be insulin resistant, which can lead to prediabetes. And so if there's obesity present, then definitely weight loss, okay, and improvements in the diet, like reducing refined sugar intake, can improve the underlying PCOS. So I would say, if you're not trying to get pregnant, I still want you to improve your diet, lose weight. That can help the pro-inflammatory markers that we see in PCOS. But if you want to get pregnant, achieving pregnancy is often motivating, okay? That we know that losing weight can decrease inflammation, can improve insulin resistance, and actually improve ovulation. So I also do for women at baseline metabolic testing. So hemoglobin A1C to look for risk of diabetes. I sometimes even look at insulin curves in a glucose tolerance test, because it's really remarkable. I see many women who have normal hemoglobin A1Cs, meaning no diabetes, but marked hyperinsulinemia. And then we talk about sometimes adding in agents like metformin that can make them more sensitive. So really it's tailored to what are the metabolic parameters we can improve to make you healthiest, because when I graduate them pregnant after their OB or after you as the high risk OB, I want to minimize their risk of gestational diabetes or C-section, preeclampsia, all those things. Okay, but if we exclude other causes of irregular cycles and say this is likely PCO related and ovulation, then oral medications that we can use as first line agents to help you get pregnant, letrozole. So letrozole is first line for women with PCOS. And the classic medication we used to use is called Clomid or clomiphene citrate. But there was a study that came out in the New England Journal in 2014 that was a head-to-head trial that looked at Clomid versus letrozole for women with PCOS. And clearly letrozole was better for achieving live birth rate, ovulation, and the rate of multiples was the same. The rate of miscarriage was the same. And so what letrozole is a medication that essentially helps to temporarily improve the hormone balance to allow for the brain to encourage ovulation.
Okay.
And so there are things that we can do for women with PCOS that are pretty straightforward and simple to assist in ovulation, that can help women to regain ovulatory function. I will say that when we talk about PCOS, okay, I see extremes in terms of the ovarian morphology. And what I mean is that when we talk about your ultrasound and how many eggs we see, the higher the AMH, the higher the number of eggs we see, the more likely an ovary is to be resistant to letrozole or clomiphene. Okay. And so we sometimes have to change medication dosages or improve insulin sensitivity, but letrozole is a first line agent to help with ovulation in PCOS.
Yeah. So, as far as the treatment and that goes, I talk to a lot of general OBGYNs and I talk to a lot of REIs. And I think for the general OBGYN, they do have certain skill set to help women with this condition. But if I caution women that if it's taking too long or you're not seeing results or you don't understand what's going on, I always recommend seeing a reproductive endocrinology and infertility specialist, because this is their expertise. And I'm not knocking general OBGYNs at all. It's just that this is what doctors like Dr. Schutt do all day, every day. So, and I also want to say that, and I hear this all the time, well, if I go to an REI, they're just going to sign me up for IVF. That is simply not true as well. I think that the goal of any REI is to help you achieve your goal, as Dr. Schutt has said. And if that's pregnancy, then they want to do it the easiest way possible for you and the healthiest way possible. So, again, I encourage you can always do a consult with an REI, just, or to get a second opinion. There's nothing wrong with that. It does not mean that they're going to just put you in the IVF bank and say, oh, or she's just going to do IVF. A trip to an REI does not mean it's going to be a $20,000 IVF cycle. So I always try to get that out there to encourage women to get that second opinion or just do the consult. And it may be something as simple as lifestyle changes, taking the medications that Dr. Schutt recommended. So it doesn't mean that I don't think your goal is to put everybody on IVF, right?
Okay, that's a great message, and I think it's important to say. But I see many women who think they might have PCOS, want to learn more about it, and don't want to have babies for a long time.
Right.
And I love that, because to me it's being proactive. It's being, hey, I want to know about my health. I want to know what's going on. Is it actually PCOS? And so you're exactly right. And that's a misconception that I think really important to dispel. My goal isn't to put anybody through an IVF mill. I think, again, your health is the most important thing. If you want to have a family, I want you to be a healthy mom and be healthy for your kids and feel good and live well. And so, you're my patient first, and then we help you have a baby. But you're exactly right. There are things that we can do before IVF, 100%, and that's not my goal.
Right. And and for someone like myself who does take care of a lot of the women who do get pregnant and are high risk or have metabolic syndrome in the form because of PCOS, either with high blood pressure or diabetes, it's so much better to have that under control before the pregnancy occurs. Playing catch up when you're pregnant is not ideal, because that's setting you up for further complications. And sometimes we can never catch up, especially with the diabetes and the hypertension if they exist. So, seeing someone like Dr. Schutt to get this all under control before you even get pregnant not only makes you healthier, but makes you healthier going into the pregnancy, which is what I prefer. For sure.
100%. And then there's actually even mounting data that our health during pregnancy affects the health of our child long into life. And so PCOS that's unchecked can increase the risk of your daughters developing PCOS. And so if we think about even, our children 20 years from now, how healthy we are during pregnancy can impact their health. It's pretty powerful.
Yeah. And I talk about seeing REIs and consultation, with family planning or before, but I also encourage seeing someone like myself. If you've had PCOS and you have high blood pressure and or diabetes, and you're planning a pregnancy, seeing someone like me so I can come up with a plan for you once you do get pregnant, or make a recommendation, you know what, you might need to do this before you get pregnant. I love those types of consults because, again, proactive is ideal, especially in a woman with any kind of chronic medical condition. So that way we can get things under control before the baby even gets there. And Dr. Schutt is so right. I know I don't want women to feel like we are blaming the women for what their child's health is going to be, but there is such a thing as fetal programming, where how the baby is formed in utero, if a woman has any kind of chronic medical condition, it can affect certain things that the baby may develop over the course of its lifetime. So pregnancy is a very powerful thing for obvious reasons. So anything we can do to get you in the best optimal health before getting pregnant is obviously ideal. You want to, go ahead.
Well, I was going to say, I think often talking to patients about weight loss can be very daunting. And I say, we have very realistic goals. So, I don't have specific weight goals for patients. And like I said before, thin women can metabolically be more sick than women who are obese with PCOS. Right. And so really my goal is to get you as healthy as possible, but I don't want anyone to think that we're weight shaming either. That's right. Not part of what we want to do. We're all on the same team. And I do send lots of patients to see high-risk OBs like you to get counseling before pregnancy about, hey, here's what we're going to do to monitor your blood pressure and so forth.
Yeah. So you wanted to talk a little bit, which I think is great, about the diet and PCOS and fertility. Let's talk about that. You touched on it a little bit. Let's talk about it.
Yeah. Okay. So I think the most important thing is to keep it simple. Okay. So when I have women coming to talk to me about PCOS and we say, look, you have marked hyperinsulinemia, I want to kind of explain what that means. Okay. And so for women, we all know what diabetes is, people who have high blood sugar. Okay. But we don't just go from normal blood sugars to high blood sugars with no intermediate. And the intermediate is that this hormone called insulin is made by our pancreas. And insulin rises steadily to try to keep up with our blood sugars until one day it can't anymore and we develop diabetes. And so insulin is released in response to certain foods that we eat. Insulin also can worsen many PCOS symptoms. So it worsens the production of testosterone. So women who have PCOS and have acne or hair that bothers them, different foods that we eat can make that worse. And then again, if you want to get pregnant, anything that worsens your insulins can also make our fertility goals more difficult. So there are lots of, fad diets out there, and I would hesitate to recommend any fad diet. Okay. But in PCOS, we know that sugar intake worsens PCOS. And so when I say sugar, not all sugars are alike, but processed or refined sugars like high fructose corn syrup. So for women with PCOS who are looking for simple things to do, cut out sodas. Okay, sodas provide no nutritional benefit, right, and are high in sugar. And try to maximize or increase natural carbs. Okay, so complex carbs, increasing lean proteins, increasing vegetable and fruit, making small changes by reducing sugars, because that's going to reduce your inflammation. Okay, we know that women with PCOS have high inflammatory markers. And so I'm asked a lot about, will cutting out dairy or gluten improve my PCOS? And to be honest, the data is not very clear about this, but really sugars are the primary culprit. And of course, cutting down overall sugar intake can also help with our weight loss goals. The problem also with sugar is whenever you eat sugar, like a piece of cake or a bagel, your sugar spikes, your blood sugar spikes. And in response, your pancreas sets out a huge bolus of insulin, right? Yeah. And then your sugar crashes and you're hungry again. And so it's a cycle that we can break by trying to reduce the sugar that we take in. And actually, I refer many of my patients with PCO to nutritionists, kind of to go over a food diary and figure out what triggers there might be that we can improve.
Yeah, and one of the things I see a lot in women with diabetes going into pregnancy, whether they're obese or not, because not all women that get diabetes in pregnancy are obese. We can throw a gazillion units of insulin at you, but that's not my goal. My goal is not to, your sugars are high, here's some more insulin, here's more insulin, here's more insulin. Being exposed to that much insulin, both for mom that high of sugar, both for mom and baby, is not healthy. And the dietary things that Dr. Schutt is talking about are even more important. if you're having issues with your sugars in pregnancy as well. So getting that lifestyle kind of down, if you will, and not having to do it when you're pregnant and hungry all the time is even more ideal, because I know it's hard. I send women to nutritionists and they know on paper what they're supposed to do, but making those dietary changes with the baby growing inside of you is, I'm sure it's difficult. But the answer is not to Dr. Clark will give me more insulin and my sugars will go down. That's not the ideal way to do it. So these, especially if you have PCOS and you have the time to work on your diet and get that to where it's a part of your routine, and so it's not that big of a deal once you get pregnant, would be so much more better for you and baby.
Definitely. And I think, I look at all us, the two of us and the patient as a team, that really when the patient graduates off to you or the OB, that we've all already had a talk about what our risk factors are for pregnancy. And I see my goal as a fertility doc is to help, again, maximize the health and the counseling to give the patient the tools to make changes that make her the healthiest during pregnancy. Because anything we can do to minimize the risk of preeclampsia, gestational diabetes, I think is a worthy goal.
I agree. All right, I'm going to take a moment here and go through and get some questions, because I think there's quite a few. So hang tight. Let's see. And
then one thing I wanted to bring up too, Dr. Oh, go ahead.
No, go ahead.
I was reading a question here about metformin. So in the news lately, there's been talk about metformin and safety. And so the reality is that there are certain kinds of metformin by lot number that may have some additives that are not safe. And so if you're on metformin or your doctor wants you on metformin and you have concerns about this, then we can go back and figure out, make sure that your metformin is safe. But so generally speaking, we still use it. We still like it. But there has been some news about it lately.
And someone right here, Paige, wrote, she feels like PCOS has such a negative stigma. Why do you think that is? It is a medical condition, just like anything else. Why do you think PCOS does have such a negative stigma?
I think it comes back to the name first. There's a drive really to rename this because the term polycystic ovarian syndrome has this negative connotation. And I think just misunderstanding of what it actually is, or generalizing what the symptoms are. I think just not clearly understanding what the disease process is gives it a bad rap. Yeah. But I think it's really important to know that whatever your goals or your symptoms are pertaining to PCOS, we have very effective ways of treating those things. Yeah. Agreed.
Okay. So with potentially more follicles, are you more likely to have multiples? Is there a higher chance to release more than one egg when you do ovulate?
Okay, that's a great question. The answer is actually no. So the risk of twins spontaneous conception is about 3%. And whether we use Clomid or letrozole, it's about 8% per cycle. And I don't want to get too into the granular details about the hormones, but in PCOS, again, you have this high level of AMH. And one important role of AMH is to make you less able to ovulate spontaneously. So that medication, letrozole or Clomid, just helps you to release an egg. But because you have many eggs in your ovaries, doesn't mean you're going to release more than one all at once.
Yeah.
But yeah.
Okay. For someone with PCOS, is an IUD the best way to protect your fertility chances for later in life if you're not already ready to have kids? So I'll let you answer this, but I hear all the time, I've been on contraception for how many ever years. That's what gave me infertility. Is that true?
No. And I think it goes back to, again, that misconception of, it must have been the pill that caused these problems. Actually, the pill is just masking any underlying hormonal imbalance, right? So you come off the pill and that's actually what your cycles would have been like. Yeah. So no blame there.
Yeah. So I think it's important, you got to know why you went on birth control. And I think this is important for actually young women who go on birth control at a young age and just, what do you tell them? She started birth control when she was 16 and she's been on something till she's 30. Do we take a holiday from birth control to see what our cycles are like? What do we do? Because what you don't want to do is stay on it until you decide to get pregnant. And then, like you said, something's been masked all these years.
Good question. So, I mean, the reality is, in adolescence, it's normal to have irregular cycles,
Yeah.
when you're young. And actually, many women go on it also because they're having really painful, really heavy periods.
Mhm.
And so we think we might be seeing less endometriosis in women actually because many more women are on either an
Yeah.
IUD or birth control pills. But I guess what I would say is this. If you have a relationship with a general gynecologist and you've been on some form of contraception for a long time and you want a baseline fertility evaluation, they can certainly initiate that. Just kind of see, hey, what is my ovarian reserve? Or just check baseline labs. Make sure your thyroid function is normal. But there's not really a compelling reason to have to come off the pill
Okay.
unless you decide you want to change kind of what you're doing. In
Okay.
terms of the
Yeah.
IUD is a great way to protect the uterine lining. So using either a Mirena IUD, which is my favorite because it often results in lighter periods or no
Yes.
periods. So it's uterine. Importantly, with the IUD, the ovaries are still working normally or
Okay.
not normally if you have PCOS. So meaning the ovaries are still making high levels of androgens. And if your symptoms in PCOS are hair that's really bothersome or acne, the IUD will do nothing to improve that. So the IUD is a great option to regulate or to improve the menstrual cycles and
Menstrual
protect the
cycles.
uterus. Yeah, but they don't do anything to change the other symptoms.
Okay. So Sarah is asking about the difference between a cyst and a polyp. Sarah, I don't know. You didn't say where you got the polyp removed from. Do you want to tackle that, like ovarian cyst versus, I'm guessing, an endometrial polyp? What's the difference?
Mm-hmm. Great question. So ovarian cysts essentially or most commonly develop after ovulation when that kind of ovulation site sticks around and can grow a little bit. And
Mhm.
those can either result in cyst rupture that can cause pain or discomfort. Now, endometrial polyps, let's talk about. So those are basically kind of overgrowth of the uterine lining. If you think of like your front yard, the grass, if it
Yeah.
grows a little bit too thick and like a little, mushroom pops up, that's a polyp.
Yeah.
Polyps are definitely more common in PCOS.
Yes.
So I remove a ton of polyps and they're almost always benign. But it's important that if you have a change in your cycles, you have heavier cycles or bleeding between your cycles, we can certainly evaluate to see if uterine polyps develop. So ovarian cysts are outside the uterus
Yeah.
in the pelvis, and polyps are more commonly in the uterine lining.
Yeah, and within the uterus.
Yes.
Uterine cysts are very, very, very common. And sometimes women know they have them, sometimes they don't. Sometimes they find out because they had imaging of their pelvis for whatever other reason.
Mm-hmm.
Ovarian cysts aren't always problematic. So if you've got a random ultrasound that said, oh, you have a 2 or 3 centimeter cyst, that's not necessarily something to be worried about. But if if you're having irregular menstrual cycles, especially if you're wanting to pursue fertility, there's ways that they can evaluate the lining of the uterus and they may find that there's a polyp there. So
Mm-hmm.
if you went in and took out an endometrial polyp, whether it's 1 or 5, could they grow back?
They can grow back, and we do see that they can grow back. And so typically, if we're taking out uterine polyps because we're trying to get pregnant, my goal is to help that woman get pregnant before they could come back. But they definitely can come back. And we don't know why, but some women are definitely more predisposed to polyps.
Polyps,
I
yeah.
also just wanted to comment real fast that PCOS does not result in an increased risk of painful ovarian cysts.
Okay.
So I commonly hear a question,
Yeah.
well, will PCOS cause me to have more pain in my ovaries or more cysts? And the answer is no, they're completely different. And like Dr. Clark said, actually every month, if you ovulate, you're making a functional cyst, right? Because the ovulation site is about a 2 to 3 centimeter cyst, but it goes away. And so often these are incidentally found.
Yes.
And they almost always go away on their own. And having PCOS does not mean that you are more predisposed to have those cysts.
Well, I will also say a 2 to 3 centimeter cyst can hurt because I know I used to have them when I was having regular periods. And since I'm 46, I'm not menopausal yet, but and I'm not on birth control anymore, but since I had my twins, but I get those little cysts, which is why I went on birth control many years ago before. So they can be painful and they can hurt. I know when I have one, but it doesn't mean it's something that needs to be urgently taken care of, surgically removed, or anything like that. So they are pretty common with each menstrual cycle that for women to develop, a cyst.
Exactly.
So when you were talking about the dietary changes that you recommended for a woman with PCOS, Sadie added, what about diet sodas? Let's talk about diet sodas.
Ooh, that's a great question, Sadie. And I have
Yeah.
strong feelings about this. Okay. And I'm going to say my disclosure is I occasionally have diet sodas, okay?
Mm-hmm.
But for the purposes of metabolism and PCOS, they're a bad idea.
Yeah.
And the reason is that you can't fool Mother Nature, okay?
Yep.
Mother Nature, even if you drink a diet soda, that fake sugar, whether it's aspartame or
Yeah.
Splenda,
Mm-hmm.
whatever it is, that fake sugar, though it has no calories, it actually changes your insulin sensitivity and makes
Yeah.
you more insulin resistant.
Yeah.
So it's ridiculously powerful. But if you know, for weight loss purposes, it can help. But even calorie-free sugars change your metabolism and can worsen
Mm-hmm.
PCOS. So I'm a fan of spark, okay, you know, or lemon in your water.
Yeah.
But you know, artificial sugars don't fool Mother Nature. Yeah.
Right, right. And I think that back when, oh gosh, when did diet sodas become popular? Years ago. And that was the thought that, oh, it's so much better than regular soda, but it's not true. It's not, especially in someone that does
Mm-mm.
have an underlying metabolic syndrome or diabetes. It's not any better to take sodas. And also, if you're wanting to
Mm-hmm.
become pregnant, I'm going to tell you, you need to be drinking water. So drink more water. My
Mm-hmm.
favorite thing to tell patients to do, because I'll be honest with you, I hate the taste of water. Water has a
Mm-hmm.
taste to me. I add a little bit of the concentrated lemon juice. That's how I can tolerate it. So I'm never
Uh-huh.
going to fault anybody who doesn't like the taste of water. I get it. But I don't even advocate the
Mm-hmm.
Mios or the little quote unquote sugar-free things that you squirt into water.
Mm-hmm.
You know, if you're going to add a little flavor, just a little lime or a little lemon juice is the best way to do it, especially if you're wanting to get pregnant or already pregnant.
Totally agree.
Yeah, it was so hard for me to drink
Yep.
all that water when I was pregnant. It was so hard. But I added lemon juice and I could do it. Okay, and then Sadie had also asked about, and you already talked about this, metformin and PCOS for infertility. So
Mm-hmm.
Sadie, if you want to go back and listen, this conversation will be on my Instagram Live TV or Instagram TV. So were there any other comments that you wanted to add about the metformin with PCOS and infertility?
No, I mean, I think it's a good adjunct. You know, I might ask for you, Dr. Clark, to comment on when you inherit a patient who's
Mm-hmm.
pregnant on metformin, how you manage that.
Mm-hmm.
But certainly certainly it can help improve your insulin sensitivity. It's safe when you're trying to get pregnant. It might even improve ovulation in women
Yep.
who are resistant to letrozole or Clomid. So I'm a big advocate. Now, metformin can get a bad rap because of the side effects. Okay,
Mm-hmm. Yeah.
so some of the side effects commonly are, like stomach upset or some diarrhea. And one of the reasons why that happens is that metformin in part works by limiting how much sugar you absorb through the
Yep.
gut.
Yeah.
So if you eat less sugar, okay, then you will be less prone to develop those side effects, and over time they get better. So I'm a big advocate for metformin.
Yeah, so for me, when I get them, obviously if they were diabetic and taking metformin for diabetes, I absolutely keep them on it. If they had a diagnosis of PCOS, but not necessarily diabetes, I may have them check their sugars and see what they're running, checking hemoglobin A1C. But if it's a low dose of metformin and they were doing really well on it, I'll keep them on it. You just have to watch and make sure that it's not going to bottom out your sugars, which I've never seen that happen, but I'm not going to say it can't happen. So that is a conversation. And let me back up. If you're on a medication like that and have been under a doctor's care and you find out you're pregnant, and I'm just going to throw this out there over here. If you're on any medication, your knee-jerk reaction shouldn't be to stop it, especially if you're on something for, this is off topic, for mental health disorders or anything like that. That's not the answer. So you could always, if you find out you're pregnant and you were on these medications, call the OBGYN, get your new OB appointment and say, hey, I'm on these medications. Do I stop or not? That's the best way to handle that. And I digressed a little bit, but I saw the opportunity there and I'm going to take it. Yeah. So yeah, I'm not opposed to keeping women on metformin if they were already on it, especially for diabetes diagnosis before they got pregnant. Okay. Would cutting down caffeine to reduce body inflammation, ovarian cysts, low progesterone, would cutting down caffeine, I guess, help reduce body inflammation, ovarian cysts, low progesterone, and irregular ovulation? It's kind of a very complicated.
Okay. Yeah. I mean, there's some loose association with increased caffeine intake and pro-inflammatory markers in the body. I would say, specific to the question about low progesterone, that's tied directly to not ovulating. So if we can get you to ovulate or get you on a hormone regimen that kind of keeps those hormones in check, that will correct the low progesterone. But the low progesterone isn't, I guess I would say the lack of ovulation is not tied directly to increased caffeine intake. But back to what Dr. Clark was saying, hey, we're trying to cut out fake sugars before you're pregnant anyway. Same with caffeine, limiting caffeine intake. So
Yeah.
If you're trying to get pregnant, I think everything in moderation is important. And I
Yeah.
say don't restrict and don't cut out all caffeine. But in general, 200 milligrams a day of
Or
caffeine,
less.
or like 2 cups of coffee or less,
Yeah.
is best.
Right. This is a good question. Are women with PCOS at a higher risk for ovarian torsion?
That is a very good question, and the answer is yes and no. Okay, so ovarian torsion, to back up, is when an ovary can twist on the stalk or the blood supply and cause basically decreased blood flow and oxygen to the ovary, causing severe pain. It's a surgical emergency.
Yeah.
Exactly. And so the risk factors for that are if you have a larger, heavier ovary, typically with a cyst over 5 to 6 centimeters. Some women who have PCOS do go through IVF. And those women who, have PCOS tend to make more eggs during IVF. And so theoretically, because the ovary is bigger, heavier with more eggs, but the absolute risk of torsion is very low. So that's important. So the risk of torsion is very low with PCOS in general. But the risk factors for torsion, again, are a large ovarian cyst, which can occur during IVF.
Yeah, and that can occur just in general in women as well.
Yeah.
Sometimes the cysts just get big and for whatever reason, and they can torse. So I agree. It's not necessarily a much higher risk because you're PCOS and or going through IVF. So, okay. How to increase fertility? Let's see. How does birth control protect the uterine lining?
That's a great question. So birth control pill provides both estrogen and progesterone.
Yeah.
So two things. One, it helps you to have regular withdrawal bleeds. So you're kind of get rid of that lining, but it's giving you that balance of estrogen and progesterone so that you're not seeing too much of one hormone or the other.
Yeah. And in protecting the uterine lining, what does that mean? That means we don't want it to overgrow or get what we call turn into endometrial hyperplasia, because having a long-standing endometrial hyperplasia or an overgrowth of the endometrium is not healthy, and it could, in worst case scenario, turn into endometrial cancer. So having that balance of hormones so that a woman is shedding that lining as she should be monthly is ideal. I recently read that women with PCOS have higher fertility rates in their late 30s and early 40s. Is that true?
Well, I guess I would say again, yes and no. And that comes back to that women with PCOS have a higher number of eggs on average than other women. And so if in your early 40s, you don't have PCOS, you may naturally have a lower egg count or ovarian reserve. But women who have PCOS in the 40s tend to have a higher egg count and might respond better, have better fertility to treatments. So yes, and interestingly also, if you have PCOS and you're younger and have very irregular cycles, as that ovarian reserve comes down into a more normal range, you may resume normal cyclic periods and have regular ovulation. So that kind of that can happen in response to decreasing egg counts into a more normal range.
Gotcha. Okay, and this is a good question. Should women with PCOS take additional supplements while trying to conceive? I don't know what additional supplements means, but is there anything else that a woman should be taking? She's got a PCOS diagnosis and she's trying to conceive naturally.
Okay. Well, any woman should be on folic acid. So if you're not using contraception, you're not preventing pregnancy, folic acid is important to help prevent, spinal defects, but there's no specific supplements specific to PCOS.
Right. And I would also caution, if you're trying to get pregnant and or you're seeing a fertility specialist, you got to let them know all those things that you're taking. Over the counter, under the counter, behind the counter, anything you're taking, because I get the feeling that a lot of women feel that, it's natural because it's at Whole Foods or it's at Trader Joe's or my friend saw it and it's organic, and you still have those things largely are not being tested. So we don't, even though natural does not mean it's okay, especially in fertility treatments. So your doc needs to know what you're taking because they may have very strong feelings about what you're taking one way or the other. So be sure to not leave that out when you're seeing someone.
Yeah, thank you for saying that, because actually some over-the-counter supplements are harmful. Some can interfere with ovulation. So there's one in particular, it's very common. It's called biotin. And it's commonly in hair and nail supplements. Well, biotin actually interferes with many of the hormone tests that we do. and it can change how we treat you. So definitely just let us know what you're on. If you're seeing an acupuncturist and taking supplements, let us know so we can review them with you. Yep.
Yeah, I think the whole natural thing is, I think, and you could agree or disagree, but they think it's okay, but we still don't know what's in all of those things. And I know I've talked to a lot of REI docs, and they know what they like and they know what they don't like. And I think once you get to that point, whether you're seeing an REI or a specialist for any medical condition, there has to be a certain level of trust. So if your doc is saying, you know what, I don't agree with this, you shouldn't be taking it, then you shouldn't be taking it. Otherwise, well, why else are you there? So please listen to your doc, especially when it comes to fertility issues, so that they can give you a recommendation on whether or not you should take that. And I'm not knocking social media mom groups. I think they're great, but sometimes that's where this comes from. And I want to caution women that just because there was a chain of 175 comments that agreed with taking this supplement doesn't mean it's right. Okay, so I'm probably going to get a lot of hate on this, but I see it all the time. I see it. And what is your take on that? I'm sure you have patients come in and say, well, I heard about this, the X, Y, and Z.
Well, I completely agree with you. But I love when patients come and say, hey, doc, what do you think about this? Because no judgment on my perspective. I would much rather you say, hey, I read about this. I heard about this. Just be open so we can go over it together. And if there's no compelling data that's harmful, sometimes I'll say, okay, go for it. But just being open and letting your doc know what you're on is important. Yeah.
Yeah, I agree. That's what we're here for. We want to know everything. Sometimes too much. Okay, well, I think let me see if there's any more questions about there being different phenotypes. Somebody is asking, you spoke early about there being different phenotypes of PCOS. Can you briefly talk about them and their differences?
Yeah, definitely. So I'll say, just broadly speaking, if we think about kind of what classic PCOS was thought to be, it was thought to be tied to irregular periods, high testosterone, higher likelihood of being overweight or obese. Okay, now that we're looking more into metabolic changes, we're seeing other types like lean PCOS, where there is a woman who is actually thin and more predisposed to having absent periods. And so we see different gradients of testosterone levels or hyperinsulinemia. So really, if we think of those three legs of the chair, the hyperandrogenism, the irregular cycles, and the ovarian morphology, one of those typically dominates the PCO phenotype. And so if it's the ovarian morphology or the hormones or the irregular cycles, every woman's different with PCOS. So, but importantly, again, if you're thin with PCOS, you still are predisposed to some of the metabolic changes. And so knowing about your insulins, your sugars too, can be important.
Yeah. And that's a great point, because I think when I was training, it was automatically assumed if a woman was overweight, or she had to be overweight or have abnormal body growth or have a certain body type, that would indicate that she had PCOS. And that's simply not true. We've thankfully learned a lot more over the years about PCOS and how to treat it, especially for those that are not seeking fertility, as well as those that are seeking fertility. So it's important that I think it's great that we've come out such a long way. Okay. So, any other points that you can think of that we have not talked about? Anything else about PCOS that you want to get out there?
Well, I think we've covered a lot today, which I've really enjoyed doing. I would say if you're at home and you're thinking my periods are irregular, I don't know what to do, we would love to talk to you about it. So either your general gynecologist or REIs, we definitely help treat and evaluate women who are not trying to get pregnant. And so, but being young and having irregular periods is not normal. And so let us help you figure out what's going on, because knowing more about your health is empowering and can help you understand what's going on now and help you stay the healthiest for the long term.
Yeah, I totally agree. I'm all for that. I think the time to figure all this out is not once you're a little bit older and wanting to start a family and then trying to, as I said before, play catch up or figure things out. If there are red flags early on, address those red flags, not only for your health, but also for your future fertility as well.
Agreed.
Okay, well, I really, really appreciate you taking this time out on a Sunday. And I'm sorry about the earlier bad connection, but the Wi-Fi here is shoddy. But anyway, it worked out.
No
so
worries.
This will be live on my Instagram TV and in my stories and feed after this. I'll also post it up on YouTube, and I'll leave the Instagram handle for Dr. Amy Schutt so that you can get a hold of her. And you are located in Houston, Texas at Baylor College of Medicine. So how can a patient come to see you? How can a woman make an appointment to come see you?
So I practice at the Texas Children's Family Fertility Center. We have a women's hospital, and you can look us up, Texas Children's Pavilion for Women Family Fertility Center, and learn more about our clinic. I also have the link to our hospital clinic website in my Instagram profile.
Okay.
So click the link; it takes you right to my practice.
Okay. Well, enjoy the rest of your weekend, and thank you again. And this will be up soon.
Thank you. Have a wonderful vacation.
Thank you. I will.
Good
Thank you
talking
so
to you.
much. Bye-bye.
Bye.